Good morning, students. We are going to begin our vital signs unit. This unit will take several weeks, and we will talk about each one of the vital signs individually. We'll practice them all individually. You will be expected to also learn to do vital signs in the lab and accomplish that goal in clinicals. We start with remembering that vital signs are a baseline. They reveal a change in the patient's condition. This includes all of the vital signs, including oxygen saturation. The fifth vital sign is often called pain, or pain is often called the fifth vital sign, which means that as a nurse, we should always think when we're taking vitals to take a moment to get a pain scale from that patient and chart that information. This is performed during routine assessments and periodically through the shift, and as a nurse, in your scope, you can decide to do them more often than they are ordered, but you do not have the scope to decide to not do them when they are ordered. Evidence-based practice says that automatic blood pressure results Starting again, automatic blood pressure machines do not give the same results as manual methods. We will want you to learn to trust your ears and your own manual blood pressures rather than the machines. You will not be allowed in clinicals to use the machines because you will need to start to rely on your own senses to record a blood pressure. Historically, the systolic and diastolic values are lower on an automatic blood pressure machine. When we talk about patient-centered care, we want to make sure that we're sensitive when we take vital signs. First of all, not to be too quick, not to move in and out so quickly, not to just expose the patient's arm or chest when you're listening to a heart, and at least explain what you're doing so that patients have time to prepare themselves in certain cultures for you to do their vital signs. A nurse caring for a patient is responsible for these vital signs. Now, oftentimes we delegate this, but the decision whether to withhold a med or to change a treatment is based on the nurse's judgment, not the judgment of the nurse-assisted personnel. So you will need to have a good collaborative practice with your NAP to make sure that they will record and report to you when the vital signs are not within the normal limits for that patient's size and condition. You should always know your patient's usual range of vital signs. For example, if they run a top number in the 90s or 80s always, then it will not be an unusual finding for you to have a low systolic blood pressure. Again, we should know the medical history and the medication. For example, if I have given a medication in the morning and I take the blood pressure at noon and it's quite a bit lower after giving a medication, I would assume that that is due to treatment, and because I know their medical history and their medications, I will have that be an expected finding. When you are taking vital signs, make sure that the environment is very standard, meaning within the same standards that you normally take their blood pressure. For example, if you take it upon waking each day, then taking it at noon on the second day, you may yield different results. You will find in the lab that you will gain your own organized and systematic way. For example, if some students prefer to do blood pressure first and temperature last, that is no different from the student who decides to do pulse first, or vice versa. Be aware of your patient's condition, and of course you need to collaborate with your provider to decide the frequency of vital signs. If you have a patient whose vital signs are very stable and you have an order for every 2-hour vital signs, certainly within your scope to ask the provider if we could minimize the amount of vital signs per day for that patient. I will be, as the nurse, analyzing the results and incorporating those findings into my nursing diagnosis and my plan of care. I will communicate and document significant changes, and things that are significant should be recorded and reported to the provider. We'll start with temperature. Body temperature ranges in the adult from 36 to 38 centigrade or 96.8 to 100.4. It would serve you very well to remember exactly those numbers because that will be information that you need to know. You can see on the right here that there are many things that will change a patient's body temperature, and we will discuss this in lab in depth, but you also have to know that a person has a baseline. There may be certain senior citizens especially, or young adults, who have a baseline oral temperature of 96.7, which seems low, but when they always run in the 96 to 97 range, even though that seems low, for them that may be normal. As I said, we'll discuss in detail those things that modify or influence a patient's body temperature. There are many sites with which to use. For your validation on vital signs, you will need to know all of these sites, specifically the ones that I will point out now, and the differences from one zone to the other. Tympanic would be in the ear. Urinary bladder is something that's only used in ICU. Temporal artery would be used by all of us who use the forehead monitors. Rectal, esophageal will be something in the ICU, as will the pulmonary. There are also an axillary site, which is underneath the arm, and oral, but they are not considered core temperatures. So, to reiterate, core temperatures, which means the inside of the body, accurately can be measured using a temporal, a rectal, and a tympanic, which would be in the scope of practice of the LPN. Surface measurements can be done on the skin, which perhaps might be the forehead or another type of skin monitor, the oral cavity, which is under the tongue, and the axilla, which is in the armpit area. The task can be delegated, but you have to collaborate with your NAP to make sure that they understand normals and abnormals and that they bring that information to you. Also, which route you would prefer for them to take the temperature. We will always record and report what we found and make sure that abnormal findings are reported. When we teach, we perhaps may need to teach about maintaining a body temperature, things that may help a patient to hold their body temperature if they're hypothermic, or things that may influence their temperature when they have a fever. These are things that we will teach, and we will talk a lot this semester about signs and symptoms of infection, one of those being a fever. So we will talk in detail about how to manage a fever. Our geriatric population oftentimes has a lower baseline temperature because of the physiologic differences in their circulation. And at home, there are many things that might influence the temperature. Perhaps it could be that that person doesn't have good heating, or that they like the house very cold. At home, oftentimes people will use the mercury type, which you stick under the tongue and read the temperature on the mercury thermometers. They're not very common anymore, and we rarely have to teach how to use those. We're moving on to a radial pulse. The radial pulse is in the wrist on the thumb side. Remember that your radius and your ulna are the two bones in your forearm, and your radial pulse is on the side of your radius, which is the thumb side. You will need to learn to be very sensitive about how to get a radial pulse accurately, and we oftentimes use this data at the radial artery to tell us a comparison between that and the apical pulse, which is the one that you will hear with your stethoscope. What I'm saying there is that they should be the same. Every time my heart beats, there should be able to be a pulse palpable, the radial area. If not, I'm worried about perfusion and circulation. This can be delegated. Of course, if there's someone who's tachycardic, which means over 100, or bradycardic, which means less than 60, that would have to be reported to the nurse. And then as a nurse, I will decide whether or not that information needs to be reported to a provider. We will record and report what we saw. Normals, of course, just go in the chart. Abnormals are given to, perhaps in the case of an LPN, the charge nurse or RN, or perhaps to the healthcare provider. Whatever is the normal policy of the place where you are working. When we're teaching, we teach about pulse rates. I will tell you that oftentimes people are unable to take their own radial pulse. They don't have enough sensation and they can't discern it properly. So many times as a nurse, I've recommended a patient to get a blood pressure and pulse electronic device that will help them to be consistent. When we teach about normal heart rates, we need to know the baseline. Those people who are athletes might have a lower resting heart rate, and those patients who are ill might have a faster than normal heart rate. Peripheral vascular disease, which means disease in the vessels at the periphery, may make it hard for you to get a radial pulse. Apical just means your stethoscope is in your ear and you're listening on the chest wall. This is what we do as nurses to get an accurate pulse. And the goal here is also to understand the function of the heart, because I'm listening to the organ through my stethoscope. Each pulse should have two sounds, an S1 and an S2. That's commonly known as a lub and a dub. Those sounds are produced by the valves in the heart, and we will talk in depth about this in the lab. We will draw this out. Your A&P teacher will also go over it with you, and we'll talk about it at length. I want you to understand that you are not hearing the muscle of the heart beating, you are hearing the valves opening and closing. When I hear two sounds, for example, lub-dub, that is one heartbeat. You'll have to learn in the lab how to be listening at the mannequin or one of your partners in your cohort to listen for both heart sounds, which is a normal finding, and counting it correctly. We can delegate, however, when we're using the apical pulse as a diagnostic tool to give information to the provider, we oftentimes will then do it ourselves. In other words, we will not base a change in treatment on a nurse-assisted personnel's assessment of an apical heartbeat. When I'm listening on the chest, as a new nurse, you're listening for just several things: rhythm and rate. Is the rhythm regular, and is the rate too fast or too slow? Those are the things that you need to be able to discern early on. We will talk about the apical pulse and the 5 or 6 places on the chest where you will auscultate. We will talk about the point of maximal impact, which is the place where physiologically the heart meets the chest wall, and you can palpate or hear a very loud lub-dub at that area, and it's called the PMI. We will talk about that in the lab as well. When we're teaching patients who take medications at home, as I said, I oftentimes will have my patients show me that they can do it correctly, or perhaps get an automatic pulse blood pressure machine that will keep the information for them digitally and easier for them to read. As I said before, Oftentimes we use the apical radial pulse as a comparison. Am I hearing a lub dub on the chest but not feeling a pulse at the radius? If that is the case, I'm looking for inadequate circulation, peripheral vascular disease, or something that has decreased the flow from the heart to the small artery in the wrist. A nurse and a second healthcare provider can take them separately but simultaneously and compare measurements. And as you get more practice, you will be able to do them both at one time. This is something we do not delegate. It is a diagnostic tool for nurses for their own diagnosis and for their treatment plan. We will collaborate, but they will not be as the NAP assessing apical pulses. Now we're talking about respiration. Remember that respiration includes ventilation. Respiration is the exchange of gases, and ventilation is the movement of the chest with the diaphragm up and down or in and out. Again, for respiration, you are listening for regularity and rhythm and rate. So is it regular, and is the rate within normal limits? This can be delegated unless the patient is unstable. Perhaps they are having an allergic reaction, or they are reacting to a medication such as an opiate that has made them less level of consciousness. So for abnormal findings, of course, the NAP would come get us, and the LPN would perhaps then report to the charge nurse or RN before the provider is called. We just record and report what we see. When there are normals, as I've said before, we record them. If not, there may be a decision that has to be made, perhaps increasing the oxygen or giving the medication for anxiety or for pain. All of those are decisions that may be made using the vital signs as a baseline information. When we're talking about breathing here, we often will have to talk to our patients after surgery or illness about breathing deeply, coughing, getting their chest to expand as far as possible. I'm sorry, there was an interruption there for a moment. We will be looking at expansion of the chest, depth of respiration, work of breathing. We'll talk a lot about accessory muscles. That means you're using other muscles in your chest and neck and back to help you breathe. And when we get to the unit on oxygenation at week 12, we'll talk a lot more about this. In home care, we have many patients who are on oxygen and who have known diseases. The environmental factors may be something like smoking, maybe pollution, maybe other people within the home. So home care is very unique in that we don't have the ability to make an assessment always, but most of the time it involves in-depth questioning of the patient and family to find out what the environment is like. Now we go to blood pressure. We will bring up a movie and a exercise in the lab where we will start listening to blood pressure, and we will practice it on the mannequins. But what I want you to know is that the systolic and the diastolic are the two numbers that we're going to report. Most of the data says that there are 5 sounds. This is very hard to discern in the beginning when you're just learning. But just know that as you're listening, it gets less and less intense and becomes silent. And we will learn in the lab how to discern what that information means. Now, when we're talking about blood pressure, there is hypertension, which means high blood pressure, hypo, which means low blood pressure, and we'll go in depth into that in the lab. There's also a definition under hypertension for prehypertension, and a definition under hypotension for orthostatic hypotension, also known as postural hypotension. It has to do with your posture for the fact that you're lying, sitting, or standing. As is seen here on the slide, we like to have the cuff be not the entire length of the upper arm, and it should go around the arm more than one time, 1 1/3 times or 1 1/2 times, so that it is not too small or too large. A cuff that is too small will give a wrong information, and a cuff that is too large will give the wrong information. So hypertension, hypotension will be discussed in the lab. Blood pressure measurements can be delegated. However, when there is an abnormal, perhaps the patient has very high or very low blood pressure, as an LPN you may need to report that to your charge nurse to collaborate and perhaps give that information to the provider. We record what we see, document what we've done, and if we have made any calls or given any medications, we will also record that. Risks for hypertension will be talked about at length in the lab, but I will want you to know by the end of this semester the risks for hypertension and what makes a person at risk, and you will learn in the lab the exact time and position to take a blood pressure. When we're talking about our geriatric population, many of them are susceptible to injury or bruising from too tight of a cuff, and it does cause them pain. This can cause an increased systolic blood pressure. They also can have postural hypotension, which means that their blood pressure drops upon standing. We will practice this in the lab. You will need to know the values that are appropriate to a person that I may give the diagnosis to of postural hypotension. At home, we always want to make sure that the patient is using the same equipment during the same time of day on the same arm and recording information that is consistent. When we use an electronic device, which you will not be allowed to do for your validation, it is very nice when you have someone who has frequent blood pressures to be able to set the machine for every 15 minutes. We use these very frequently in the critically ill, in the ER, in ICU, the OR, after surgeries. But for nurses, we also need to be able to rely on our own senses to get the information from the patient to make sure that we're double checking what the blood pressure machine tells us. I will tell you that historically, when a person has an irregular heart rate, perhaps tachycardia or bradycardia or an irregular heartbeat, these machines cannot be trusted to give diagnostic information, so you will need to trust your own ears. This can be delegated. Oftentimes our NAP use electronic machines, and they will chart the information in the chart and report it. We're moving on to oxygen saturation. This is very non-invasive, just goes on the end of the finger. It uses a light probe to measure hemoglobin oxygen at the periphery of the body, earlobe, finger toe, forehead. The normal pulse ox, this is something you will need to know, is 95 or greater. That's in most of the adult population. Of course, those that are sick or have lung diseases might have different normals. We delegate this to the NAP. Again, they will notify us if they are too low, and then we will perform an intervention. Otherwise, normals are oftentimes just reported.